All right. Well, thanks for joining us tonight. Tonight we're going to talk about the enigma of sleep apnea, and Laura Wells is here along with Dr. Ray Kiefer and Dr. Chris Catalano. They're with Innovative Oral Solutions, and I'm going to give it to Laura to take it away.
Thanks, Mary. Thank you for joining us. We are presenting on the enigma of sleep apnea. And I think we came up with that because there's so much question about sleep and what do we do with sleep and how do we diagnose sleep. And I thought this was a really interesting topic to get into from just a global interest. I think it would be a fascinating topic. Really, my whole team is so into it. But one of the things we really thought about is why is sleep apnea so confusing in terms of treatment, in terms of saying, okay, what's the right thing to do? How do we identify it? And one of the things that we've come to the conclusion of is to remember that sleep disordered breathing means there's an obstruction or a resistance in the airway. And I think what gets confusing is the airway encompasses both the nose and the mouth on inhalation and exhalation. So it's both of those things. And so when we talk about sleep, I'm going to go into the definition of the 5 different sleep disordered breathing diagnoses, but I want everyone to remember about breathing. So we're talking about there's an obstruction. That's what sleep apnea means. Apnea means no breathing. And so we're going to go into that some more with some more detail. So the types of sleep disordered breathing, there are 5. And they include obstructive sleep apnea, central sleep apnea, mixed sleep apnea, upper airway resistance syndrome, and snoring. And I think most everybody knows these 5 diagnoses. I'm not sure if they knew it was under sleep disordered breathing. And a bunch of pulmonologists want to change it into breathing disordered sleep, but that's a whole nother topic that we're talking about. And what I want you to take note of is all of these 5 diagnoses have to do with an obstruction of an airway or resistance on either inhalation and exhalation. And that's really important to remember when you're thinking about treatment or what you're going to do with the patient for a long-term plan. So the prevalence of sleep disordered breathing is getting higher and higher and higher. And a lot of the literature suggests that it's because people are living longer. Some literature suggests that it's because of postural differences, because we're on screens so much, and in front of our phones. And those are the 2 schools of thought as to why it's getting worse. Obstructive sleep apnea, they assume that the prevalence is about 30 million people in the United States, while only 6 million are diagnosed, and about 50% of them have an effective treatment plan. So that really leaves a lot of people not breathing well, which contributes to, remember, heart and lung issues, migraine issues, clotting issues, and disruption in digestive tract. Sleep apnea is about 1% of the population, or 3 million people, and typically diagnosed over the age of 40. Mixed sleep apnea is about 1.5% of all of the people diagnosed with sleep disordered breathing, which is about 4 million people. So at this point, we're already up to about 37 million people with disordered sleep in the United States alone. Then we get to what dentists see a lot. I know Ray and Chris, both of you are very familiar with this, upper airway resistance syndrome, and that's about 5.3% of all sleep disorder diagnoses. And it's most common in women, as you guys know. And there's typically a look, I think, that I've seen and that I've read in the literature with a high arch palate, both narrow jaws, narrow maxilla, longer neck. But I didn't know that 32% of those diagnosed with upper airway resistance syndrome are of East Asian descent. So it's more prevalent in that population. I think, Ray, you told me that. And I fact checked you. It's true. And then the final one is snoring, and that is from mild to severe. And in the United States, they just did an estimation of 37 million people say they snore habitually, which breaks down into about 27% of the population. But when you add all of these 5 diagnoses, it's about 50% of our population with sleep
Yeah.
disordered breathing of some type or another. That's a lot.
Yeah. And, I just listened to the Matt Walker podcast, and
Yeah.
Matt is a sleep specialist. He said globally, they're looking at 1 billion people. They said that it's about 12 to 20% struggle with sleep apnea worldwide. That number is about 1 billion, and it's still not really well understood. And it's not, as far as like diagnosing it. So they think it could be more.
Yeah. I believe that. I really think that, and that's one of the things that I want to talk with you guys about too, is talking about successful strategies and identification and treatment plans and what works and what doesn't, so we can get this better. And I think we're really getting into a really nice diagnostic way of assessing sleep and what a good treatment plan is, and we'll go into that some more. So everybody knows obstructive sleep apnea. We talk about it all the time, and why I'm highlighting it, I won't go into huge detail because you guys probably know this, but obstructive sleep apnea is classified by an AHI index. And that means the apneas, which is when we stop breathing completely for 10 seconds or more, with the hypopneas, which means there's a shallow airway, a shallow breathing, reduction in airflow, partial saturation for 10 seconds or more. And then how they figure this out in a sleep specialist is what they do is they take the number of apneas plus the number of hypopneas and then divide it by the number of hours of sleep. And that gives you your AHI score. So for example, if a person has 50 apneas and 75 hypopneas, you add those together and divide it by 6, and that person would have an AHI of 21 or moderate obstructive sleep apnea. What I'm learning in all of this literature and reading and treating all these people with obstructive sleep apnea is there's nothing else defined in it other than this number. So it's not identifying which airway is occluded, what are they struggling with, where is the struggle, what part of sleep. And so Ray and I were talking about it earlier this week about how he was telling me REM sleep really reinvigorates the brain and calms down stress levels, anxiety level, whereas the deep sleep helps the body heal. So where are these apneic events happening? Where are the hypopneas happening? What part of the structure is it happening in the nose and the sinus complex? Is it the back of the throat? Is the tongue retracted? Is it in the throat or the epiglottis? There's so many areas.
Mm-hmm.
And so I think it just gives this one snapshot, but not the whole global picture of the person, where we can get such a stronger treatment plan. So I thought it was really interesting just reading in all the literature, and this is still the way we do it now, is by AHI, which a person is already in a sleep disordered disease.
Yeah.
So you guys know all this. So this is supposed to be a typical mouth, but I love this picture because it's a mouth breather. It's like, you got to be kidding me. I have to put this.
That is exactly where we're at in medicine and in dentistry. I mean, as far as that poor understanding, where we didn't really know the distinction about nose breathing and mouth breathing until recently, really.
Yeah,
I mean,
no,
for the general population. Yeah.
Yeah, honestly,
it actually is so medicine right there.
This is it. I mean,
that's
right
it right
here.
there. That shows it all, that we don't even understand that part.
No. And so I think it's so cool. When I saw this, I'm like, that's going in for sure.
I love that. That is so funny.
It is. So this is normal. And this is sleep apnea, means there's an obstruction, right? Complete obstruction and resistance. So what this is looking at, same open mouth, same long philtrum, right?
They use the same face, just different insides.
That's right.
Can you explain, Laura? Yeah. Could you explain to the students that are watching, or the audience that's watching, what the mouth breathing, nose breathing, what we are talking about? Because for a lot of people, that distinction may not be understood. But can you show?
Yeah, for sure. So
what happens with the tongue and stuff?
Yeah. Mm-hmm. So here with mouth breathing, what you could see is the tongue isn't connected to the palate, right? Because the mouth is opening. So what it's doing is creating a space, and the tongue's heavy. So it often lays then in the bottom of the mouth, right? And that's what this is showing. This is actually showing an open airway of the oral cavity. And so the goal is to get these lips closed, and so that we breathe through the nostrils here into the sinus complex, which goes into this pharyngeal space and goes down. These structures right here, this is the epiglottis. This is the valleculi. So when we swallow, this is something that we always watch it as a swallowing specialist to see if there's any pooling here. And then under this epiglottis here is the windpipe. So it goes down and then it reroutes into here. And so with an open mouth posture, if the tongue's down, our tendency is going to go this way because it's the path of least resistance, right?
Can I add on, Laura?
Does that make sense?
Yeah, and I just wanted to mention too, as far as growth and development is concerned, we need the tongue and a closed lip posture in order to get the best growth and development for a facial complex and not have vertical growth.
Oh, so true. So that's the other piece. The tongue's heavy, so then we end up with long face syndrome, right? And then a retracted chin, which then further pushes the tongue into the back of the pharynx, into the back of the throat. So this, yeah.
So the normal, I guess what I was asking also is that when the picture of normal with a mouth breather, that shouldn't look like that. It should look like the right side, right? Like,
yeah, well, not necessarily. Some people do have a low resting tongue posture and they just hang out there. But I think what would happen with this is they would get some obstructive breathing, right? And some resistance. It might be a hypopnea versus an apnea to start. And then it develops in over time into an apnea. Yeah.
When they're nose breathing, is the tongue, does it lift up? Is that what's essentially going to happen?
Right. So when you're nose breathing, the tongue lifts up into the palatal space like this. And so the idea then is when it lifts up, it contracts and it lessens the volume of the tongue back here in the back of the throat. And so this allows all this air then to go into the airway.
Right.
Right.
Okay, cool.
That makes sense. That was a good question. Central sleep apnea, I think everybody knows central sleep apnea is when our diaphragm and lungs stop breathing for an unknown reason. And typically in what I've dealt with, it's typically related to a neurological condition like myasthenia gravis or Parkinson's. And it's one of actually the markers that you'll find in a pre-existing neurological condition that hasn't really sprung up yet. It's also related to a recent or rapid descent from high altitude above 8,000 feet and also narcotic use. In terms of remediation of central sleep apnea, 20% remediate or resolve by themselves, and that's typically with people with drug use or mountain climbers, but not typically related to people with neurological conditions. And then mixed sleep apnea is a combination of both obstructive and central sleep apnea. And the only way to do this test is not with a home test. This is diagnosed only on an overnight sleep study. And it has to be, it's specialized when treatment isn't working, they'll send them in for an overnight sleep study. So the different at-home tests don't work in this case for diagnoses. And then guys, this is your area, that's for sure. So upper airway resistance syndrome right here is characterized by frequent nighttime arousals in response to a respiratory effort, not necessarily an obstruction. And it's caused by slowing or blocking the air in the nose and throat. And I don't know if I even love this picture, but I think it's one of the pictures that the ADA has on to designate upper airway resistant syndrome. The presence is getting higher and higher in this diagnosis. And so I think things will be changing in terms of what the look is or what's happening with it. So that means it's hypopneic, not apneic. And that means it's not obstructed all the way, but they're having difficulty. Any resistance in breathing in the nose or mouth is going to cause clenching, because the idea with clenching is it contracts the muscles around the neck on the front and the back. And when they contract, they get smaller and longer. And so that allows the windpipe to be able to stay round and patent. So the clenching opens up the airway that way. And I think when you think about it, you think clenching is going to bear down on everything and close everything down. when essentially it's not changing the structure of the trachea, the windpipe, it's changing the structure of the surrounding intrinsic and extrinsic muscles of the airway. And that's what clenching does. Does that make sense?
Yeah.
Yes.
Okay, so snoring types. So the fifth and final type of sleep disordered breathing is snoring. And there's 5 types of snoring. And I think this is another thing that we miss in terms of what's our treatment plan, because if you're a nose snorer or a mouth breather or a tongue snorer is when the tongue drops down in the back of the throat and it has a different quality sound, or a palatal snorer, which is where the soft palate and the uvula are really weak, and so it flaps in the back of the throat, or a combination of all of these. My treatment plan is completely different for each one of these snore types. And I think what we have on all of our health questionnaires, do you snore? My husband's a terrible snorer. I'm sure you guys hear it all the time. And so it's really important to differentiate between a nose snorer, a mouth breather, a tongue, somebody with the tongue dropping in the back of the throat, a palatal flutter, or a combination of all. And I have an example of how to test all of those types at the end of this in terms of treatment. So you can assess what type of snorer are you, or what type of snorer is your patient. Okay. So this one, this is just a test instead of treatment. So one way to check to see if somebody's a nasal snorer through their nose, you can tell from congestion. And one of the ways to have your patient do it when they're sitting in the chair is just occlude one of the nostrils and have them inhale deeply. And if you see this nostril collapsing, the chances are it's called an anterior nasal valve collapse. So that means there's going to be resistance on inhalation. So when they take a breath in. So we have all these people that are sleep taping, but they have a anterior nasal valve collapse. And so what happens then is you start hearing this through the nose. And it's because that tissue is weak, and so it's collapsing into the septal wall. And so when you're sleep taping, you have to be careful of that. So instead, if you see that somebody has a nasal valve collapse and that the nostrils collapsing, you would help that person to give them, you could get a breathe right strip, you could get a nasal cone dilator, you can get a barrel cone dilator, you can go to your ENT also for some suggestions. They'll put stents up there, or Vivir will also make the sides of the cartilage stronger so it doesn't collapse. So there's a number of ways to do it. You wouldn't tell somebody that has a nasal valve collapse to use nasal spray, because that's not going to help the valve collapsing unless you have a combination of congestion up here, which is causing this to collapse so much. So it's really important to differentiate between the two of them. What type of snorer are they? Because they're not in a disease diagnosis yet when they're a snorer. They haven't hit apneic events. They're just having restrictions. And so I think as practitioners, it's really important to be able to differentiate where are we on the scale of disease. And I'll show you more about that coming up right here. Okay, so this is looking at AHI versus RDI. And I think you guys are familiar. Want me to just say it anyways?
Yeah.
Okay, so the apneic hypopnea index is the diagnosis, the way we diagnose sleep apneas, mild, moderate to severe. Anybody that has a sleep apnea, even if it's mild, is considered a disease under the medical diagnosis. So this person is already diseased, and we don't want our patients to get to that point. We don't want them to get to the level of obstruction that they're in a disease state. So if we can prevent it by having knowledge about what is under the level of disease here, then we want to look at the respiratory disturbance index, the RDIs. And on all the sleep tests, everybody has different sleep tests. We have a sleep image here and we have the watch pat. And so when we look at those images, we look to see there's AHI, there's sleep quality, latency, there's AHI, there's RDI. And often when we see these tests, AHI might be maybe 3, so it's still considered within normal limits, but the RDI will be 19. and that's respiratory disturbances during sleep. That RDI is suggestive of what's in store for that patient if it's not addressed. So it's really important to say, okay, these RDIs are below sleep apnea and have to do with snoring and nasal or oral resistance. So what are we going to do for that? We have to make sure that we're addressing is if that person's a snorer, what type of snorer are they, and what are we going to do? And I have a whole list for you guys to say, if you're this type of snorer, use this or that. Or if they're upper airway obstruction, respiratory syndrome, you guys, you do your CBCTs, and Ray, we have a picture, I think of one of our patients to show with expansion. That's super effective. But she had an opening, and we'll go into this. It's the next slide. I'll put it over here, and if you guys have more questions about this, I can go back. But this is one of the patients that Ray and I are treating. So Ray, do you want to talk about the CBCT and what you see?
So the one on the left is the original one. So I look at tongue posture. If there's any black space above the tongue, that's something that I look at. I look at the length of the soft palate, position of the lower jaw, and the overall, the red that you see. I have software that can measure the volume of that too, the pharyngeal space in the back. Mm-hmm. So after, well, she's really in the midst of treatment, but I took a opened up on the right side. Now, it's probably a little bit impacted also by head posture. Her head looks like, I mean, we have to sit them down in for my CBCT, and sometimes the head posture will be a little bit different. So there's some variability just based on head position. Mm-hmm. But overall, with her, we have had an opening with the pharyngeal space and a forward movement of the lower jaw, which brings the tongue fit.
Yeah, so you can see that.
Yeah, it looks even longer.
Yeah, do you see how, so there's open black space here. This space is definitely more open, leaving more room here for air, which is going to go down into here.
And Ray, what did you do? Sorry, Laura.
No, you're okay. What'd you say, Chris?
Yeah, was that, how did you do an expander on her? What was the?
I did a controversial appliance, the AGA appliance on her.
Yeah.
Which brought the upper teeth forward and allowed the lower jaw to come forward.
Okay.
Yeah. And so now we have her here at the clinic. And so she had night terrors, some snoring, wow, definitely issues with sleep and chronic congestion. So what we did is we did jaw releases, tongue strengthening, and we're doing nasal release treatment on her, and she's doing the My Mouth Works exercises. And now she's sleeping through the night for over 6.5 hours. And her night terrors are pretty much down to about once a month. But she was waking up 2, 3, 4 times a night with night terrors, just not sleeping at all. She had big dark circles under her eyes. She looks so good. We just saw her this week. She looks awesome, and her teeth are looking great. She's feeling really good, and such a different attitude. She has the coolest attitude now, and she's getting stronger and more confident. And it's really fun to watch the progression. Yeah,
that's awesome.
It's really, really good. Another patient that we have here. So he was a big snorer, and had significant jaw pain, and this guy in particular, do you know how many times he had braces, Ray?
Something like 3 or 4 times. He had a bunch of times.
Yeah. And so with him, and he also went to myofunctional therapy prior to coming here. And so this is after, I think it was a 3rd or 4th time that he's had braces. And he said this was his last ditch effort. And the reason why he chose the treatment plan is because it was more of a holistic approach. He's super good about where's his body. So you can see I had a posterior open bite from the last clear tray experience that he had.
Well, I think he was also wearing an orthotic though that brought his jaw forward and created that posterior open bite.
Is that right?
Yeah, I'm pretty sure he came with an orthotic.
Gotcha. And so his midline, you can see a midline shift. You can see it's more significant on his right side versus his left side in terms of the opening. And that definitely tracked with his tongue positioning. When he swallowed, it would come out more significantly on the right side versus the left. He had headaches. What else, Ray? Can you remember from your perspective?
Yeah, he had TMJ, pain, headaches, poor sleep. He was a snorer.
Yeah.
So at least from my perspective, I figure I changed structure. So on the left-hand side, initial, you can see if you compare it to the final that I've expanded, it's just dental expansion, which can impact. I mean, he had already had some recession. It looks like the recession got a little bit worse on the lower and perhaps a little bit on the upper as well. That's one of the risks you take when you're dentally expanding people. Mm-hmm. But what it does is it also makes more room for the tongue. And then making more room for the tongue makes it easier for him to do what Laura does as far as conditioning the tongue and giving it muscle tone and a place to go. Mm-hmm. And so that's why I love working with Laura, because she addresses the soft tissue problems, and it's helped to support what I'm trying to do with changing the structure.
Yeah, you know what? I also remember, it's coming to mind. He also had a lingual and labial frenectomy.
That's true, yeah.
And so that was something, he had it before and it grew back and he went for time 2. And so with that, he did the 4 weeks pre-exercises and did the 4 weeks post-exercises, and then paired it with the myo activities, and he ended really well. He's doing great. You ready for the next one? All right. So this is super interesting because I work with a few sleep doctors, quite a few sleep doctors, and obviously a lot of dentists and ENTs. And the idea of CPAP being 34% successful, it just blows my mind. And, you know, I go back to thinking about, remember, we're only looking at apneas and hypopneas. We're not looking at the structure in terms of function. And so if we do that and we think by slapping a CPAP on somebody that's going to help the AHI, a lot of times it makes it worse. A lot of times it's intolerable. And a lot of times it promotes mouth breathing. And so I really think that the dental community needs to look at this and say, in terms of assessment, objective measure assessment with airway, it's something to take really seriously and say, we have to make sure that the structure and the function are at a particular level of resistance that allows for CPAP to be successful. And really part of that is oral dissociation, stability of the tongue, and making sure that there is the ability to breathe through, inhale and exhale through the nose. It's really important. I think I'll have you guys talk about expansion and jaw repositioning, but surgery is super effective, 70 to 90%. But relapse is so high because there's no work done after surgery. Yeah, on making the muscles stronger, on training somebody to breathe through their nose and not through their mouth. So it works.
Yeah, what's the statistic as far as what wins out? Is it soft tissue beats out bone? Like, you know, as far as like, let's say we move
things first. Yeah.
Isn't soft tissue the strongest? Like,
yeah, soft tissue is the strongest, and soft tissue guides bone. I mean, our muscles in our back can create a scoliosis from asymmetry, right? And so somebody can end up with an S or a C scoliosis just because of the way they work. And then so you take a picture of their spine and it's moved. So you can see definitely by big tongue thrusters, you see that opening or that moon shape in the front. is from that muscle, the tongue, just hitting and hitting and hitting and constantly hitting the teeth to create that bone, the opening in that bone. So I think it's so important. Same with turbinate reduction. So many of my patients, they're on 3 and 4 turbinate reductions. And the thing is, the turbinates fill up with nitric oxide and they have the reduction, but they're still mouth breathing. And so what happens is the turbinates fill up again because they don't have the air flowing over to release the nitric oxide through the nose. And so they just blow up again. And so the surgery is a teeny little piece of it, but we have to make sure that we do the exercises to support the structure that's impacted. And so oral appliance therapy with moving the jaw forward is 30% successful because it's only for certain types of snore that it's effective and only for mild sleep apnea. And it's used for all types of snoring, sleep apnea, upper airway resistance syndrome. But if you don't have an open airway with the jaw coming forward and it's not objectively tested at the beginning, the chances are it might not work. Well, 70% chance it might not work. And so it's really important to look at everything from a whole perspective to say, okay, how will I know that if I pull the jaw forward, it's going to work? Well, one of the ways to do it is have your patient stick their tongue out really far and bite on it and breathe through their nose. And if they can do it without struggling, you know that's possibly without doing an objective rhinomanometer. You know that, okay, this is a possibility and a potential to reduce the resistance in the back of the throat. I'm going to give a shot for an oral appliance, an anterior mandibular oral appliance to use this and see if it's going to work. It's a good shot. And so that's something to consider, to just do that quick tongue test. A lot of people do that and they're like, I can't breathe because they're mouth breathers because they have so much nasal resistance. So it's a really quick way to say, hey, is that going to work or is that not going to work? If you have resistance,
I like that.
yeah, it's easy. And if you have resistance in the for the airway period and you're in an apneic event, you should have somebody test them properly with objective measurements so you know where you start in terms of breathing, tongue strength, lip strength, and then muscle stability. It would be really important to show what's going on with that patient and how the treatment plan is going to work. So the only other treatment, there's myofunctional therapy is what we do. And typically they'll drop, if you do traditional myofunctional therapy, it drops from a moderate to a mild. And that's pretty typical if you're in a strong program. And so it does help. So if you pair myofunctional therapy with oral appliance or myofunctional therapy with dental expansion maybe and oral appliance therapy, your chances are getting better and better with each of those treatment plans. And then the other treatment is medication for daytime sleepiness. So I know a lot of professionals prescribe medication so people don't fall asleep during the day, or they over caffeinate themselves or drink Monsters or Red Bulls. And so that's not good systemically. It can create so many other sequelae that we could spend like 3 classes talking about.
Exactly.
But basically, if you're looking at this, it's kind of like, I don't know, I wouldn't drive my car down the freeway if I knew I had a 60% chance of getting in a car accident. I would avoid it. And so you can see why so many of these strategies are avoided. I mean, Ray, you did such a good job with the expansion of Haley at one of our patients. And she, I mean, talk about that. How, if she didn't have myo and nasal release technique, what do you think?
It's incredibly important, I have learned, to have a good nose breather. If they're not breathing well through their nose, then they're probably clenching at night. And if they're clenching, then I can't expand as effectively as if if the muscles are fighting what I'm doing, then I'm not going to get the expansion.
Yeah.
And you're going to have typically more issues with periodontal issues as far as recession and bone loss. I mean, I would like everyone to do myofunctional therapy that I treat. I think it would completely improve the results and the stability of everything as well.
Yeah. How about you, Chris? What do you think?
Yeah, I agree. Yeah, it's almost like you're fighting against a system that got them to where they are. And what I've learned from you guys is when I look at cases, I immediately go to, this is the before, like, how did they get here? And then it's like, oh my gosh, mouth breather, tongue tie, there's something that's created this. Now, if I go in there and try to fix it, what's going to make it not go back? And so I think that's with all of these, like, you're right, you have to address that. And I think that's where dentists, as a dentist, we're apprehensive because we don't have a lot of education in this field.
Right.
We don't have mouthfunctional therapists that are really on their game that can help us. I'm lucky. I do have some local. I have you as a resource. I think the app is also that's going to bridge so many people that don't have access to this to, like, say, hey, this is a tool that can help you reach your end goal. I mean, I've seen even, like, mandibular, like, jaw repositioning surgeon, like oral surgeons, oral surgery, where a young class 2 patient went through this full-on maxillofacial surgery, and I look in their mouth and they have a massive tongue tie, mouth breather, and I'm like, you're going to go right back. Like, they never even looked at that. I would think that would be, along with the jaw function, they would be like, and when I talked to the oral surgeon, they were not even concerned at all. Like, they didn't even understand it and even get that subtlety of, how did this person get here? How can we fix that? Because I know relapse for some of those maxillofacial surgeons their relapse is high.
Yeah, it is.
They are. And
Yeah,
so now that we're all
that's a great way. I love how you keep saying, how did they get here? How did they get to this spot? Some of it's genetics, right?
Right.
You might be born with a high palate, whatever, it might be genetics, but so much of it isn't.
No, yes, some of it is the genetics, the tongue tie. And then that creates this. It's not necessarily, I think for orthodontists and dentists, we've looked at things like, oh, they inherited class 2, but it's like, no, they inherited the tongue tie. They inherited the nose breathing apparatus, whatever their system is. I think it just developed that way, but it's not, I think we don't know what we don't know. And I think this world, like I always say, that the tongue is the most ignored organ in our body. We don't even have a specialist except for you. Like, a mouthfunctional therapist is the only, you have cardiologists, nephrologists, neurologists. What about the tongue?
Oh my gosh, it's a really big deal. It's such a big deal. It drives everything. It's the eyes in your mouth. It's the lymphatic drain system. It's the thing that allows us to breathe. Talk. There's so much to it. And it's really interesting because as you go through this, you start learning, oh, wait, from babies, because I worked in the NICU for 7 years, when I see newborn babies being born and they're having feeding issues, there's always a hip issue or one hip higher than the other where we do an adjustment to be able to allow the jaws to work symmetrically. And so without that, they have feeding issues, and they come and they say, oh, they have latching issues, but you want to go straight to the hip. And it's the same thing with adults. I want to make sure that's why we do posture, breathing, jaw, lips, tongue, speech, and swallowing in that developmental order, because it's the same thing from when you're born to when you're 5, going through growth spurts, to when you're 90. It's the same thing, and you have one hip up and one shoulder up, and you have a crushed airway. And so that changes function, and the whole thing that we need to look at instead of disease is, how do we change this function so it can accommodate to allow us to be our best person with an open airway, without all these grabbing postures that cause dysfunction in our airway that disallow us to breathe. It's super interesting.
It is.
This is the stuff I love now too. Now we can talk about. So one of the things, and I didn't have this, but now I do, because I think some people come here, a lot of people come here and they're like, I don't know, my dentist wants me to get my breathing checked because they think I have like sleep issues or something. They're totally confused. And I mean, I know when I'm working with Ray, I know he's very concise about it, but I work with a lot of dentists, and some of them, they just know, they're like, something's wrong. Just That's what they said on the referral, like, fix this. And so we put this sleep disordered breathing questionnaire in there, and just by them having it, they come in, and it's so funny because once they get here, we have them sign it, not in the big form, but just this. And they're like, oh my gosh, I have a lot of this. I have a lot of this stuff. And so it's helped us have the patients not come in confused, like, what am I doing here? To, oh my gosh, I'm like 7 out of 10, or I'm 9 out of 10. And this, what do you mean sleep disordered breathing? And then so we can segue straight into it to say, we're going to get all this data and then be able to make you a treatment plan. And there's so much more understanding by the patient to say, oh my gosh, I get it. This is totally me. And so these 10 questions we have been using, and it's been really effective. And anybody, please use them in your form for sure. I think you guys can have copies. And if you're not, just tell me and I'll send it to you. But this is the whole thing, National Library of Medicine. There's a lot more information coming out. We just ran a study on the first 10 or 15 people that finished the app, and it was really hard for me because I was like, what if it doesn't work, And so a research team took our data from the app, because on the app there's an algorithm that shows progression. And so I have these miners that come in and take this data. So they took the first 15 people, with the permission obviously of the people, and took their data with all of their measurements, and they're running a study on it right now, and the conclusions were really positive. They keep going, God, this is so cool, and it's going to be published in a sleep journal. So stay tuned. It's really exciting. I'm so excited about it. But they're getting great studies on snoring versus obstructive sleep apnea as one of the 5 disordered breathing diagnoses. And I think that's so important, because then you have a tiered treatment. You don't necessarily put CPAP on a snorer, because certainly people with sleep apnea, 87% snore. But if you're a snorer, it doesn't mean that you have sleep apnea.
Right.
And so you have to be able to differentiate between the two. So there's studies coming out about face deformity, dental retention, speech disorders, malocclusion, tongue thrust. And then I hope with ours, the comprehensive program of looking at the whole body might really stimulate and help people learn their patients more just by taking a quick picture. And I think it'll be really helpful. We treat sleep disordered breathing on the app with a 17-week program. And so it's something that we've taken. We have a kit, and it has resisted breathing strategies, tongue strengthening, jaw stability. We definitely open up the 2 nostrils, and we recommend a whole sinus regime for the patient for the first 2 weeks. And it's been really effective because it established an open airway before we even start the exercises. And that's really good. It's been working great in the clinic. This is what I've included for you guys, because I think it's interesting to know, okay, if somebody's a nose snorer versus a tongue snorer versus a mouth breather versus somebody with a palatal flutter or multifactorial, or they might have 2 or more of these, how would we treat them in our practice to help snoring? So the male that Ray and I showed the before and after of, for him, so he was a palatal flutterer. He had a tongue snoring where it was in the back of his throat. He was also a mouth breather when we started. So we gave him the diagnosis of multifactorial snoring, and we hit him hard with all these, with all of it. And so He has an OPA.
This is great.
We gave mouth tape once he was capable of breathing through his nose for 3 minutes, or with a peak nasal inspiratory meter of 100 units of flow. And so then he had mouth tape. We gave him the exercise to do right before bed to help set the tongue and the structure in a good position. And then he was given a mandibular anterior device that he got from somebody, I don't know, I think from his dentist in La Jolla, and then nasal dilators and nasal strips. And then what happens is you open the airway as wide as it can go, and then people start saying, I notice I don't need the tape anymore. I love the mouth tape, but the nasal dilators are great when I get congested, or they might use sprays. I couldn't include those on there, but we have a whole kit here that we give to people, and it's so awesome. So this might help people as well.
Yeah.
I talked about this last time. So with the app, we scan it for your practice, and so it looks like it's coming from you. We keep data on it and then attach it to your social media and your website, which has been really effective for people. Here's a picture of the OPA, and I don't know about you, Ray, but we're having like an OPA I don't know, it's like revitalized. These things are flying off the shelves, and there's so many dentists, local dentists, that are starting to order them. I think you just turned off your microphone.
So sorry. I'm noticing I'm using them a bit more as well. It really helped with the linea alba. I like it particularly in that case.
Oh, I love it for tongue posturing because it plasters the tongue to the roof of the mouth at night.
Yeah.
So awesome. Yeah. And trimming it. I mean, Ray, and Chris, you guys have been so good about saying, okay, you can trim it and you can use it like this. It's super effective. It's a fun device, an easy device to use. So I hope that helped you guys understand and kind of have a different perspective. Like we can go into 2 and 3 and 4 more classes about, okay, now if I have somebody in those 5 diagnoses with snoring, let's review the treatment plan for each of those. I think that's really important. I definitely think the questionnaire is so helpful because it starts the conversation with the patient. And that's been really key. And just thinking about somebody with sleep apnea is already diseased, but all we know is their breath is stopping or it's restricted. And what are we going to do to help that? And so that's why it's so critical to pair myofunctional therapy, the MouthWorks program, and oral appliance therapy and or expansion, and then possibly CPAP if it's necessary. Does that make sense?
Yeah.
Chris, is your mind going crazy right now?
No, I love this.
I think it's really fun. I mean, if you think about it, I don't know. I want to do a class on how we're developing a class for assessment and objective measures.
Yeah. You know, I keep talking about Matt Walker, but his book on, why we sleep and the importance of what sleep does. Because I think a lot of people think, close your eyes and you wake up, and if you get rest, you're like, I feel great. But he really outlines in his book what is actually happening physiologically. And on his podcast, he breaks each part of sleep down, and dreams and insomnia and everything down into like little 40 minute talks. And what I've learned from it is that the sleep is so sophisticated, and it's such a refreshing part of it's such an important part of our lives. And when you have sleep apnea, the way he described it, and I thought it was so well done, is even if you have mild sleep apnea, let's say you have 10 episodes an hour or whatever of an apneic event, imagine somebody in your bedroom closing your throat 10 times an hour, and he does it all night. Then he does it the next night, and he does it for your whole life. Do you really think you're getting great sleep? And because I have a lot of patients, they say, I have sleep apnea, I'm fine, I'm not gonna do anything about it. But when he puts in that context, you realize the impact it's having on you, the fragmented sleep that you're getting. You're really not dropping into some of these really healthy layers, like when Ray was saying about the immune, the REM stage, where you're getting immunity help, all that stuff that's happening, these really rich experiences at night, you're not getting them when you have sleep apnea. You're in these fragmented, interrupted patterns. And it doesn't just let up like one night, it's every night. And when you put it in that context, it is relentless. It's somebody in your room choking you all night.
No, honestly, it really is. I mean, just imagine holding your breath for 10 times, an hour.
Yeah.
Yeah. And that's still in the mild.
That's a
That's in the
mild.
mild stage. And so,
Yeah.
that's why I think it's so important to say, okay, let's catch it before disease, and
Yes.
maybe people, if they understand and use that scale, if you have mild sleep apnea, it's still a disease.
Yeah.
And it plays on your body, it plays on your heart, it plays on your organs, all of this by holding your breath like that. Your
Yeah.
gas exchanges could be impacted. So I think it's so important to really, really say, okay, one, we got a nasal breathe, but what does that look like? Right? How effective are we at it? Can we do it? And then the other side is, how do we open this airway to stop? So there's positional changes. There's prophylactic changes that we could use with the nasal dilators and the sleep tape over the nose, the breathe right slip sleep strips, I guess they're called.
Yeah.
Definitely nasal sprays for sure. You want to make sure that I think what people do too is when they do the nasal sprays, they squirt them up, straight up, squirt, straight up, and it goes up and back into the throat. And then as they do it, they go and they sniff. I'm like, no, don't do it, because the sinuses are all here. And so
Interesting.
when you use nasal spray, you want to always use a saline first, put it up, and then turn it to the outside ear, and then squirt it so it fans the sinuses. Hold your nose for 5 seconds and then swallow, but try not to sniff, because the agents that are helping with the inflammation or the congestion in the nose can't get in there if they're sniffed to the back of the throat. You can
So
sniff
funny.
away at
That is not
saline.
known.
Yeah.
Not at
So
all.
it's like this and it's like this, and then hold it. So it can do its job, but people stay on nasal sprays forever,
Right.
and it's just like, oh gosh,
They have a huge rebound effect. Yeah.
The rebound effect it's incredible.
Yeah, that's what I've
Yeah.
heard.
And so you really want to keep it. The studies show over time, to get rid of congestion, it's fine to use it for 2 to 6 weeks. After that time, to wean off and go into a saline mist or spray. And a lot of people like the neti pot. You have to be so careful. It needs to be distilled water. It needs to be perfectly balanced. I pre-buy all my saline or get it from a compound pharmacy if I have congestion. But it's really important, because with the neti pot, they do teach you, make sure you tilt your head.
Right.
Because they want you to spray. And it's the same thing with the nasal sprays. It's really important to do. Yeah. They're making a lot of money by that sniff.
Then, yeah, they are. They're just wasting it.
Straight into the stomach, and really good to use a xylitol spray, because it coats the microbiome of the stomach. And that's really important, because all this goes into your gut. Anything you put into your orifices goes into the stomach. So using a flow, any kind of decongestant can cause disruption in the microbiome of the gut and cause some major issues in the brain.
Interesting.
Yeah, it's super cool.
Yeah, this is awesome.
So fun. Thanks, you guys, so much.
Yeah, thank you.
You're welcome.
You guys are the best.
And I don't see any questions, Laura. Does anyone have any questions that is on tonight? I don't see any questions, so we can wrap it up. Thank you so much, Laura and Dr. Catalano and Dr. Kiefer, for joining us. And we will be in touch. Thanks so much.
Thank you.
Take care.
Thank you.
Bye, guys.
Bye.
See you later.
Bye.
Take care. Bye.
Bye. Take care.
See you, Chris.
See ya.